I just want to welcome everybody this afternoon to this keynote session. We've got Dr. John Brownstein here. The session is COVID-19, the path forward, a big data approach to eliminate existing gaps in vaccine distribution and overcome vaccine hesitancy. So I am delighted to be the interviewer here with John for this session. I've gotten to know John since mid-March when I started as interim CIO at Boston Children's Hospital. And John, among other things, is the Chief Innovation Officer there. He's an infectious disease epidemiologist and ABC medical contributor and just really well known to many. So, and doing great work. So this should be a great conversation, John.
Great, yeah, no, thanks, Sue.
I do want to encourage people, if they have questions or anything in the chat while we're talking, that's fine. We've got someone who's going to moderate and tell us if there's questions that we should cover, but shall we jump in, John?
Yeah, let's do it.
All right, so you've spoken in the past about your research on digital exhaust, which I find fascinating. Data from consumer interactions with devices, social media, and more, and how it can be used to learn how they should and could be better engaged with the healthcare system. So first question is, what perspective has that data given you on more effective public health approaches to COVID as we move forward?
Yeah, well, thanks, Sue. And, you know, it's been fun to get to know you here at Boston Children's over the last several months. Yeah, so my work over the last decade, or actually more so, has been trying to think about data that exists outside of traditional healthcare. You and I, knowing the challenges of implementing an electronic medical record and extracting data out of that environment, you recognize the real challenges of building a view of population health, let alone a view of a state or a country or maybe the globe. And so we've been on this sort of search for data that can sort of exist outside traditional channels of information flow. What are the information streams that you can tap into to get sort of real-time population view of emerging health issues, whether that's emerging infectious disease, whether that's chronic conditions, health behaviors. Many years ago, we started working, recognizing that the web had huge amount of insights, a lot of unstructured data. But if you could tap into that knowledge, you could get a wealth of information about emerging public health trends. And so we started building tools that leverage natural language processing and machine learning, and started mining news and social media and blogs and chat rooms, and built infrastructure that allowed you to basically comb the web and get insights about diseases and populations. This sort of spun off a whole field of digital epidemiology, which is, you know, utilizing the massive data sets, you know, what people search for online, what they might like on Facebook, what they tweet about. All of that content has some portion of it related to health behavior or health outcomes. And if you can tap into it and use the proper types of tools to extract that knowledge, you can get incredible insights. And so we've been doing this for infectious diseases all along, H1N1, Zika, Ebola, you know, and name a particular emerging disease. And we've been working to take our infrastructure, data mining, and then eventually crowdsourcing to basically pinpoint emerging issues. And so with COVID, it was very similar in the sense that we had infrastructure already going, mining the web across many languages. And we actually identified the first signal of COVID outside of China through Chinese language media sources talking about an unusual cluster of pneumonia out of the seafood market in Wuhan. And that was, you know, the first sort of public insight about the event that we've been alerted the WHO about. And since then have been applying our sort of data mining tools to shed a light on the earliest moments of the pandemic to then, you know, the global sort of impact that it's had. And there's been many examples in which these data have been invaluable. They've been valuable, you know, in the early indications of what's happening. They've been valuable as we've tracked spread. They've been valuable. And they've been valuable in understanding behaviors, whether people adopt masking as an example, or their motivations for getting vaccinated. We started building huge amount of technology to support the surveillance of COVID in many different ways. We have a large partnership with Facebook, and they put a survey to millions of people daily about symptoms and behaviors, and that has created huge amounts of insight. We run a project called Outbreaks Near Me, where we ask people how they're feeling, but then we ask them about their mask wearing behavior or their vaccination status. Right now, we're able to get insights about breakthrough infections, as an example. And so all this data that is non-clinical in sort of its origin is providing this real world benefit from a public health surveillance perspective, and an ability to sort of fine tune interventions and target them in ways, and especially in places where we're sort of resource poor and data poor. And so that has been a real, and especially at the beginning of the pandemic, where we did not have the public health infrastructure in play, these kind of data sets were incredibly valuable.
Okay, let me just ask a follow-up question on that in terms of the public health infrastructure that you ended on. You're the expert in this conversation, okay? I've been following a lot, reading a lot, learning as we go during this whole period of the last year and a half. Public health seems to be under attack in many states.
Yeah.
I think there's a recognition that we need to strengthen our public health infrastructure.
Mm-hmm.
So everything that you were just describing,
Mm-hmm.
is this across, I mean, if we're talking the US, is this across the country and utilized in every state, or is it really variable?
Yeah, I mean, public health is definitely under attack. And I think in, some ways, public health has been, obviously severely underfunded to sort of respond to this pandemic. So, I mean, there's some blame to be placed on the CDC for some of the challenges and the lack of preparation, but mostly it's the lack of resourcing and ability to truly respond as an organization. And so, yes, like what we've seen is sort of, a heterogeneous response to the pandemic, and the application of new data and new methods, that's highly variable across the country. Some, local public health departments have been both incredibly resourced, but incredibly innovative in the ways in which they're thinking about data, but also in the ways in which they're making data available. And some have been a little bit slower to sort of think about, utilizing data. And we're seeing this play out right now in our inability to fully understand what's happening even across the country now. There are many public health departments that have slowed down their pace of reporting. If you look, I know we're all trying to create a sort of a national view of what's happening in terms of cases and test positivity rate, but the data is very, is highly variable. Some local public health are only reporting weekly, they're not capturing the same level of data. And so we really do not have a uniform representation of public health surveillance across this country. And that, we've known this for many years, but it's been especially highlighted by this pandemic.
Yeah, and we can only hope that it will be the eye opener that we need to improve that situation and greater investments. So let's talk about the vaccination rates. According to the CDC, there are approximately 1,000 counties, is that right, in the U.S. that have vaccination rates less than 30%. I assume that's the fully vaccinated. So what are the factors that are driving these numbers in these areas, do you think? And is it hesitancy, education, access, or all of the above? And what can health system and digital health leaders do about it?
Yeah, really good question. I mean, this is a real problem that we've seen across the country, that we have under vaccinated communities, and that's being highlighted by the fact that we have these surges in cases in many parts. And we know that the vast majority of the places that are experiencing outbreaks now are places that have not had adequate vaccination rollout, or maybe prior immunity, or some combination of the two. There's a combination of vaccine confidence that we know persists, and that's an area that we've been working on actually for many years, even prior to COVID, or the reasons why people decide to get vaccinated or not. And there's significant mistrust of the government, mistrust of the safety of these vaccines, mistrust of the speed at which they came about. There is a concern, of course, that these vaccines are more risky than the disease itself, or COVID in itself is not an important pathogen. And you're seeing that play out right now in places like Missouri and Arkansas, where there's major surges, and yet it's still not convincing people to get vaccinated. Now, I still think that that access plays a large part in sort of what is holding off many people. It's not that they're so morally opposed to the vaccine. It's just a combination of convenience and motivation. And so we've done a lot of work around a concept called vaccine deserts. And so these are places that just do not have the real capacity to offer vaccines to communities. And we know about 20 million people live in a vaccine desert. Yes, there's the statistics that 90% of the population lives within 5 miles of a vaccination site. Well, that leaves 10% of the population that is not within. And, we've done analyses and network analyses to show that, there are many parts of the country that are, over 30-minute drive. And so if you have a 30-minute drive, plus you're on the fence, plus you can't get paid time off, plus you can't get, childcare, or you can't afford to deal with the side effects of the vaccine, all those factors together are going to make for a decision that is sort of not in favor of getting immunized. And so what public health can do is sort of optimize the network. How do you place vaccination sites where people are? Bring vaccine to people, not people to vaccine. So, there's, mobile delivery, there's, ramping up, primary care where you can also have a conversation. There's sort of, houses of worship or other types of commercial settings. So there's plenty that can be done. We run a project called the Vaccine Equity Planner, which is all about arming public health departments with a view of where vaccine deserts are, but then also how to optimize their network too.
Great. I wasn't sure what the Vaccine Equity Planner was. I'm familiar with the Vaccine Finder, which that's where you put the zip code in, right? And you find the closest place to you, correct?
Yes. Well, Vaccine Finder was actually something we started about 10 years ago for H1N1. And then with Operation Warp Speed and the CDC, we reformulated the whole infrastructure to be part of the flow of data around COVID. And we relaunched it as vaccines.gov. And so vaccines.gov is the site that we run out of Boston Children's in collaboration with the White House and CDC. And that is the main tool that people can go to, put in their zip code, pick which vaccine they're looking for, and figure out where it is and how to make an appointment.
Right. So say more about Vaccine Equity Planner and what that's able to do and the impact of that.
Right. So with vaccines.gov, it's all about giving people a view of where vaccines currently exist in the community. But recognizing that, while we have, about 60,000 sites across the country that offer vaccines, they are not necessarily, fully optimized to the whole population. And so the Vaccine Equity Planner was designed as a way to say, okay, well, we know where the vaccine deserts are based on drive time to sites. So we know where the gaps are. We also know where there's vaccine confidence issues. We also know where, potential sites could be placed. So primary care sites, other types of commercial settings. And it would arm public health to say, okay, here are gaps that we may or may not even know. And here are some target sites that we could place vaccination locations in that would fill in those gaps and create coverage in places where, we have this issue of, there's actually there could be thousands of people that are looking for the vaccine that are not in the anti-vaccine, but they're looking to get vaccine, but they happen to be in a desert. That would be an optimal place to create better access. And that's what the site does. This is a collaboration with Ariadne Labs. And, this is something that, we're now working with local public health to really, improve the access as we're dealing with this long tail of trying to get people vaccinated.
Okay. So you mentioned vaccine confidence. Say more about that. And how does that tie to the vaccine hesitancy?
So vaccine confidence is through data that we collect via surveys. We have different data sets that we pull. One is through a collaboration we have with SurveyMonkey, where we actually query people off of SurveyMonkey surveys where they do optional surveys and get data about people's willingness to get various vaccines. And we can track confidence in each of the 3 major vaccines across the US and how they've shifted. And for instance, how the J&J vaccine has really gone down in terms of confidence. And then, we have data from Facebook. So the Facebook surveys that are being put out. So across different tools that are basically out there serving people, we get sort of a general sense of confidence, and we have high geographic resolution. So we can target down to the zip code level or county level, what the level of confidence in the vaccine, the willingness of people to get the vaccine, whether they're, waiting, and then we can also start looking at incentives. What would drive people to change their mind? Is it lotteries? Is it paid time off? Is it, what is the motivating factor for people to make a decision?
Okay, I'm smiling because and I'd be curious as to your view on this, but the lotteries, knowing that we're willing in some states to give millions of dollars to people as incentives when, you take the international issue and people who don't have vaccines, countries that, that are waiting for it, and that we need that kind of incentive here. I don't know if you want to comment on that. It's kind of incongruent.
Yeah, listen, I think, we've always taken a global public health lens. Yeah. And so when you think about vaccine equity issues, it's a bit jarring. There's, so many countries have yet to have their first vaccine. Healthcare frontline workers are still without their first shot. But then here we're trying to, encourage people with lotteries or free beer or whatever it is. Yeah. And now, of course, that's part of the conversation with boosters. What is it? Is a booster really, necessarily part of the conversation when we know, there's still this sort of, access concern across the globe.
Right. So I'm gonna pivot here to a question that we got, and then we'll come back to some of the other questions I have for you. So there's a question from Pamela Aurora. She's at Dallas Children's. The question is, can you share a couple examples of where your insights have been leveraged by Boston Children's clinicians, and a couple examples of where insights have been leveraged by the broader healthcare community? And a thank you for your leadership with analytics, John.
Mm-hmm. Yeah, on the BCH front, obviously I don't know if that was COVID specific or not, but, we have been working really hard to understand and forecast risk about COVID from the beginning. And that data, the modeling that we were doing to basically understand where the trajectory of this pandemic was going really had impact both on informing important decisions around how the hospital operations could go, because of course, knowing what we might experience in sort of the community would impact our staff specifically, but then also would impact how we deliver care to our patients. And because I also Chief Innovation Officer and run the digital health efforts of the hospital, we had the capacity to completely shift our operations to virtual care during the pandemic, and we had the underlying infrastructure and the ability. So with the insights about what's happening with COVID, married now to our ability to then pivot to digital, we could essentially lend our support to essentially shifting the ways in which we took care of the patient. So I think that probably is one of the best ways sort of internally. Externally, we've had a lot of different projects and impacts. I guess the one that happened during the pandemic is, which may be, super obvious, but we had a whole effort on the value of masking, and we produced some of the first empirical data to show that community level masking would actually drive transmission down. And unfortunately, that was a topic that was completely controversial for reasons that I really find stunning. But we had to create empirical data and analysis to show that a community that undertook masking could drive transmission down, and we were able to show that through those sort of large data sets we were collecting, and that was important insights that then sort of led to a lot of the sort of discussions at the federal level, which was really pushing masking more broadly. We've been working in a wide range, for the most part, more recently working on vaccinations, and right now a big focus on understanding breakthrough infections, and so there'll be more data around fully understanding how vaccination as an intervention is going to work over the long term.
Okay. I'm very curious about breakthrough. What's the right phrase? Breakthrough.
Infections, yeah.
Yeah. Um, yeah. Do you have more that you can say about that at this point in terms of?
Yeah, I mean, I think generally speaking, we are trying to, problem is that, we're not seeing a ton of really good granular data about breakthrough infections, so we don't have a great handle on it.
Okay.
The viewpoint is, and based on the data that we have, we're seeing it happens, but for the most part, it's happening and producing, asymptomatic or very mild disease. And the probabilities of onward transmission are greatly diminished. So both vaccines create protection against severe disease, even moderate disease, and they create some level of protection against transmission. Now, will they happen? Yes. Will severe disease occur in small numbers? Yes. And the more transmission that we have that is among unvaccinated populations, the more breakthrough infections we're likely to see, especially among vulnerable populations. So, every sort of exposure increases your probability of getting an infection. And so, even if you have you're vaccinated, if you're exposed enough times, you will eventually be infected just based on probabilities. And because of that, if you happen to be vulnerable, or maybe immunity from the vaccine is waning, whatever it is, that's, definitely concern that we have. And then on top of that, we have this concern about, variants that might evade a vaccine. And the more that we have transmission occurring in under vaccinated populations, the more opportunities we have for a new variant to emerge. And that's what we're especially concerned about.
Exactly. Yeah. So we talked about access. Let's talk about hesitancy, and how can the data be used to get people who are hesitant into the, vaccinated category. And, some of the stories I've seen lately and some of the data, that it's unvaccinated who are being hospitalized and unvaccinated who are dying of COVID, which I say somewhat, I don't know how I want to characterize it, but for people who think that those of us who are vaccinated is a great experiment and we're guinea pigs, it seems to me that there's another experiment going on, which is the unvaccinated and what's happening. People.
Yeah, it's a problem. I mean, again, like as I sort of said before, I think if you can improve access, you can actually change the conversation. I think that we have underutilized our primary care workforce as a tool to have those conversations, because most of vaccinations were occurring in mass vaccination sites or pharmacies. That's not a place necessarily that people have relationships. It's possible they do, but very often they don't. And so there's no natural conversation about a vaccine. In a primary care visit, there's an opportunity to have a real deep conversation and it lead to an immunization on the spot. And that's why there's a big focus on primary care and family medicine. As the Biden administration launched a new effort, that's part of it. Part of it also is the ground game. And I know there's a very, I guess it was a hot topic about the door-to-door conversations. I think that got misconstrued about people showing up indoors with needles in hand, ready to jab you. And it really is just about conversations and education and discussion and trying to, deal with misinformation. So that's definitely part of it as well. And so I think that's where there's a doubling down at a federal level, say, okay, mass vaccination sites worked for the beginning. They don't really work now. Now it's all about real individual level conversations where you can make a dent in vaccination coverage. And that's sort of how you deal with it. So you make it super convenient, you create conversations, and I think you make headway. You don't make huge gains, but you start chipping away at it.
Yep. So PCPs actually have, I'm assuming J&J, they have J&J available to them to vaccinate on the spot.
I think we're finally seeing it. I think it's the range of vaccines, but I think, we're finally starting to see it. I think depending on the capacity of the primary care physician, I know that there's different requirements, obviously, for freezing. But I think depending on what is possible in a primary care office, you'll see, different vaccines.
Okay, great. Do we, I'm just going to ask our moderator if there's any other questions that we should be answering. I see some stuff in the chat, but I haven't read it yet, so I'll just put that out there. Let's talk about looking ahead and the Delta variant. What do we need to be doing to prepare for life with this virus in the coming months, knowing that it's still here, it's not going away? Coming months, coming years.
Yeah, it's an interesting one because obviously in the coming months, we're thinking about schools and trying to get school systems open to full in-person learning, and making sure that what we're doing for our kids is to keep transmission down but being flexible because certain communities are going to be dealing with, flare-ups of transmission and others won't. So trying to get kids back to fully normal in-person learning as much as possible, but recognizing that layers of protection, of masking, social distancing, room configurations, ventilations, testing, all of those things will be part of the sort of the ways in which we're thinking about dealing with the pandemic for our children. I think that, we always say it's like a tale of two countries now. For vaccinated people, I think going forward, it's probably going to look like, COVID will be part of our, respiratory mix of pathogens that we think about on an annual basis. As a society, we have to decide what is acceptable as part of respiratory virus season or not. With flu season, we had we accepted severe illness and death at a level that I think was significant, and we've worked on flu for many years. That may or may not be acceptable going forward. But if we're sort of measuring against that, then depending, COVID will be with us for many years. Now, I think we've really changed as a society in terms of acceptance around masking or staying at home when you're sick. And so I think we've maybe changed, at least for the next several years. I think we may see a different attitude towards respiratory pathogens. And then I think the big question is, obviously the big unknowns are variants, or some, we're already at Lambda variant, which is 11 down in the Greek alphabet. We're churning out real variants at a high clip. So if one emerges that is problematic for the vaccine, causes severe illness, that will be a problem for sure. And I think that's the big sort of question. And then of course for unvaccinated populations, it will continue to be more of an issue because we know the vaccines work really well and seems to have very durable, long-lasting impact. So the question around boosters for now is really focused on those who might be immunocompromised, elderly that may need it, but it's not going to be a broad conversation at this point for everyone.
Okay. All right. So we have, I want to come back to kids in a minute, but we have another question for you. What is the best way we can leverage data and technology to communicate public health messages to the general public?
Yeah, it's a really good question. I would say that before COVID, we didn't even think about communicating public, surveillance data to the public. Now people are completely engaged in understanding statistics, being able to understand an epidemic curve. They understand transmissibility and mortality and infection rate and all sorts of metrics that never would have guessed that one could have sort of understood. Now we're seeing a level of sophistication on the part of public that's totally different. I think that so I think the more that we're open about surveillance data, the more that data is public, the more that's made available, it's great. And I think CDC is doing quite a good job of making that data available where they can. In terms of communication, we're seeing a huge amount of leveraging of social media. I know that I've used, Twitter and Instagram, for those purposes. And I think that we're seeing more and more. The amount of conversations that are going on those platforms is astounding, and the numbers of colleagues that I have that are using these platforms to really educate the public is incredible. And that just did not happen before. But at the same time, these same platforms, with their benefit, also have a huge amount of negative. There's
misinformation,
misinformation.
Yep.
So they opening up those floodgates means that you have an opportunity to communicate, but also it's the fight against that misinformation that's really challenging. And daily I'm faced with someone sharing some rumor about whether it's a disease or vaccine that have to sort of counter. So this is why it's so important for organizations like CDC and local public health to be incredibly involved on those platforms. Generally speaking, they have not been super involved or engaged in social media, but the more that they could be there and really engage, not in a dialogue rather than just sort of as a tool, using social media as a megaphone, using it as a tool for engagement. They don't really do very much of that. I've always felt like you could use these platforms to have much, and it's hard to keep up with it, but to do much more sort of engagement.
Yeah. Hasn't some of that changed under Dr. Walensky at the CDC in terms of?
Yeah, to a certain degree it has. Obviously, huge amount of public communication. I mean, she's done a great job of being out there, but I think there's still more to be done.
Sure.
Not everyone is watching the morning shows or CNN.
Yeah.
People are on YouTube and they're on Facebook, and so those are the places where some of those conversations probably need to happen more. And I think generally public health has been very slow to engage in those platforms.
Yeah. Actually, coming back to kids, I don't know the answer to this. I'm asking you. You probably know. Where do we stand for vaccines for kids less than 12?
Yeah, it's a good question. So there's clinical trials that are underway now in cities across the globe. Recruited about 4,500 kids. They are doing safety, efficacy trials. Mostly, it's going to be looking at safety primarily, and then whether kids mount an effective antibody response. It's really hard to do these clinical trials because if this virus is not fully circulating, it's hard to look at full efficacy. But they're going to be mostly focused on antibody response, and then of course, their assumption is that it will look very similar to older kids, 12 and over. So I think the results are supposed to come in around September, and would assume that emergency use authorization will come very quickly after that. And so maybe not right before the school year, but right at the beginning of school year, we're going to see a lot of the kids, so sort of 5 to 11, have access to the vaccines. And that will be, that's over 20 million kids in the US. So, it's a large group that will then have access to this vaccine and could really impact both their health, their ability to return to normal, but then also drive down transmission in the community.
Okay. Actually, I have a data question, and you may or may not know it, but does the 12 to 16-year-olds that were approved?
They're already approved.
Yeah. Does the vaccination rate and the hesitancy issue mirror the adult population vaccination rate?
It's interesting. Our data doesn't say it's exactly correct, because we do see vaccine confidence go down as you go younger into younger adults, because they don't see the potential value of the vaccine.
Yeah.
Because they're not the ones necessarily being the most impacted.
Yeah.
But if in the younger kids, we actually saw a huge willingness for the vaccine, and so it sort of goes back U-shaped. The issue is that
parents are saying
exactly, but then the issue is their parents, and the parents, are pretty, generally speaking, opposed. It's over 50% of parents don't want to get their younger kids vaccinated. So we have this sort of double conversation that has to take place between the child and the legal guardian, and so that is going to be even more complicated as we go younger. And the willingness to get younger kids vaccinated goes down, so it keeps going down as you go younger and younger, unfortunately.
Yeah. Okay. All right. There's a question, another one from Pamela here. Do you have a listening group in your team or marketing to follow how the social media messages are being received? John's point of the upside and downside of social media is honest?
It's a really good question. I mean, I don't think it's a formalized listening group, but we definitely have people on my team that are focused on social media, and they are, reacting to posts that we put out and responding to people and engaging in sort of, real conversations. Obviously, there is conversations on social media that are not worth engaging in, but there are many that have honest questions and dialogue, and so we do a really significant job of trying to have those conversations, engage, and use it as a tool for really try to inform people about best in class science. So that's, but I agree, like there's not enough of that being done, and because the temperature is so hot, there's very divisive conversations, not really ones that are really aiming towards agreement. But I actually have had multiple conversations on Twitter that have gone from being Twitter conversations to email to phone conversations, and really been able to engage people in sort of helpful dialogue. But that's not always the case.
Yeah. Well, one person at a time, right?
Yeah, exactly.
Yeah. There may be some more questions, so we'll see that in a minute here from the moderator. Just in closing, in terms of my questions for you. Okay. There is a question about kids here. Thank you for addressing the vaccines for children under 12. I agree with Donna that here in Utah, so that must be in the chat. We have a large youth population. Have you seen any variation so far between Pfizer, Moderna, J&J in trials for patients 12 to 16, or is it too early to tell?
Yeah, thanks for that. It's too early to tell. We haven't seen the data yet. I don't think J&J is engaged. They may have engaged in the younger age groups. We've not seen it. Right now, it's just Pfizer that's available in the 12 to 16 group, so we have no comparison. We will eventually see that from Moderna, but there's no data yet to fully understand, because right now it's only one approved vaccine that we have inside. So yeah, there's no choice.
Okay. All right, great. So my last question for you is, well, maybe it's the last. I have another one. Is there anything else you want to share in terms of what you've learned, where you've struggled, what you see for the future of public health in a post-COVID world, whatever a post-COVID and whenever a post-COVID world can be declared? I don't know.
Well, listen, I'm pretty excited. There's been a ton of innovation, more resource put into public health than I could have ever dreamed. So I think, overall, we're going to benefit greatly from the amount of people and the amount of interest, the new sort of, workforce that's probably going to want to enter public health, I hope. People that have gotten excited about it, like I got into this space because I, read the, and watched the movie Outbreak, but this is a real world version of that. So, I think that's a bigger motivator. There's also an incredible amount of tech and sort of engagement from, leading tech companies. I hope that there's innovation in startups that, there are very few startups that think about public health. My only concern is, there were a lot of people that entered in, built a lot of things and probably will walk away. And so a lot of that innovation may go sort of, go to waste because there was no handoff or no someone on the other end to really manage all those tools and visualizations and insights. So I do worry a little bit about the graveyard of all this COVID effort that, people will lose interest in and sort of just, put in the trash. So that is the worry that I have. We've had incredible engagements with, as I mentioned, large companies like Google, Facebook, Amazon, Apple. But, the question is, will we be able to retain some of their interests going forward? And that, I hope at least to a certain degree we will.
Yeah, well, there's much to learn and to be sustained going forward. I will say I am halfway through Andy Slavitt's book, Preventable.
Oh, yeah.
And I know it's not just about what's happened, but, how do we prepare for the future? Halfway through. My last question for you, for people to stay informed and continue to learn, any particular advice or resources that you would suggest?
Yeah.
Other than following you, John.
I think follow me on Twitter and Instagram. But no, I mean, obviously a huge amount of dialogue is happening in those places. A huge amount of science is getting, put to the forefront in real time. There's for infectious disease people out there, there's a network called ProMed that's a really good social networking devoted towards these kind of topics. So I highly recommend, signing up for that. And then, there's plenty of enthusiasm from, organizations like the American Public Health Association. They put out incredible content. So there's great societies out there that, where you can engage and learn and join annual conferences. But yeah, I mean, there's no shortage of, I'm sure people at this point are ready to not read about COVID for a little bit. But, there's no shortage.
Yeah. Well, yeah, I wrote about it this week in my blog, and I said, you might feel like it's behind, but it's not. No, and we still need to listen to the experts and follow the science and stay informed. Yeah. There is a question. Do you see this question from Rich Pollock? Do you see it?
Yeah, I see it. But maybe since we're at time, maybe I can follow up by email.
Yeah, that'd be great.
May not want to end off on a statistical talk about predicted death rate.
I
we're trying to leave on a high note.
Rich is cognizant of that and asking it, but maybe we can follow up.
Yeah.
Okay. I don't see any other questions. Any closing comments, John?
No, just thank you for chatting with me, and thanks to the whole group, Megan and Emily and all, to having me today.
Yeah, well, thank you. This has been great. And I think Megan may be coming on here to say something in closing.
Hi, John. Hi, Sue. Thank you so much. That was really amazing. Really good stuff. I'm excited there's some more questions and stuff that we got, and we can kind of continue that conversation.
Great.
And, get it out there. But thank you. And thank you, everybody here today. We'll be back tomorrow at 2:30 Eastern, opening with another session. So thanks again. And I look forward to connecting with all of you soon.
Great. Thank you. Bye.